take it away.
Well, some acknowledgements. We have Dr. Amanda McKenna, who is going to be presenting with us. Dr. Suzanne Sampson just introduced her. So we have a 20 years old female with a history of hyperprolactinemia that was diagnosed back in November 2020. The MRI back in that time showed a cellular lesion, and she was started on cabergoline 0.25 milligrams twice per week back in 2020 with just mild relief of the symptoms. Past medical history includes migraine with aura, just a history of COVID-19 with temporary loss of sense of smell and taste, and she was started also in levothyroxine in April 2022. Physical examination was totally unremarkable. A very young and nice girl. The MRI in this consultation, I'm just gonna scroll it. Just right here, shows a lesion, a cellular mass that is just pushing the optic chiasm. The lesion is extending up and laterally, superiorly and laterally, just causing a little bit displacement of the optic chiasm. I'm
gonna stop you there for a moment, Luisa, just to show a few points here, because that's I believe that's important should be mentioned. So you see this area here. So this is the optic chiasm. Okay, and then what you see right here, this is the pituitary stalk with the pituitary gland. So this is the stalk here, and this is the gland. Therefore, the stalk is not really compressed here, but the tumor is indeed going towards the chiasm, but there is no real, encasement here. And then the tumor is this area that you see right here. What is interesting in this tumor is this. I mean, to be fully honest, I don't know what to make of this, hypointense signal tissue here. Would you scroll this image a bit more just so we take a look at the cavernous sinus?
Yes, sir.
More. Go back and forth so we can, Go.
I think the cuts are a little bit thick. And then we're just losing it.
Go back now. Okay, I mean, that's fine. I mean, you see that this tumor here kind of like, my impression is that was kind of like not really extending laterally. I would consider this as like NOSP2, in this relationship. So although it was, very small chance of a real invasion of the cavernous sinus, in my opinion, but, not zero. And quite often, like if I don't recall right now, but if we were looking at the images closely, this could even be a 3A. And based on this lateral extension into the superior compartment, but I'm gonna see in the surgery was more like a 2.
And JP, just because you mentioned that black structure right there, which is kind of abnormal and unusual for us to see, remind us whether or not did she had any episodes of severe headaches, because that can be also hemosiderin. She could have a small bleed in the past or recurrence of bleeds or anything. Do we have anything in the history about that?
Yes,
Not
sir.
that I recall. I mean, I don't know if Luisa has.
I did see her in clinic in that was not part of the history, but certainly could be a silent hemorrhage within the tumor with the treatment with cabergoline for sure.
Thank you, Susan. Yeah, that's because I think that what makes it unusual, and it makes it a little bit more challenging for us to think of the surgery, because we know we may be finding different compartments. We don't know the attachment that they may have to the cavernous sinus and so on and so forth. So that it immediately elevates our level of complexity when we're thinking about the surgery, as JP just mentioned, in the different compartments. We know where the pituitary is, the stalk, and is leaning towards the left. But that tumor is definitely a little bit more elevated level of complexity than what we normally see.
Yeah, and in those points, as Dr. Q just, can you scroll the sagittal now, just so we can? In the sagittal, Luisa, please. Yeah, in the sagittal. Yeah, thank you. Okay, good. Stop right there. Just to show some. You see this tissue here? In this one cut, we mostly see the gland that is pushed on the left side. Okay, and then the up here, this is the optic chiasm, and up here it's HUs, and always above the optic chiasm we got the icon complex. This is what the gamma knife training is used for, for surgeons to paint the MRI scans. Okay, go, keep going. Nice. So you see the grayish, not grayish, I'm sorry, iso-intense mass now that's the tumor. Can you keep scrolling? Go. Mm-hmm. Go. Okay, let's go back one, please. Yeah, in the carotid. Yeah, no, the previous one, the other one. Yeah, nice. So here you see this is the cavernous on the right side. I'm sorry, the cavernous ICA you can see here. So this is the anterior genu. This is the horizontal segment. This is the posterior genu, and this is the ascending segment of the carotid in the cavernous sinus. So when we look at those segments and we try to understand the relationship with this tumor, we see that there is some hyperintense signal here and hyperintense signal here, and even some hyperintense signal here. So, but this one here, the difference, I know this is the dura. So we would have to explore above and below. Doesn't mean that there is tumor in the cavernous sinus. When you look just at this cut, it can be just ballooning and pushing the medial wall of the cavernous sinus laterally. But anyways, it requires assessment investigation, so one can try to maximize the resection here in this area. So let's go ahead and see what happened. So remember, pituitary is on the left side, the tumor is on the right side. The tumor is subdiaphragmatic, so there is no component in the cisterns, and it is extending, at least pushing the medial wall of the cavernous sinus on the right side. It doesn't mean that there is invasion of the cavernous sinus, and it does not mean that there is invasion of the medial wall of the cavernous sinus. However, it does mean that in surgery it would be ideal to explore that area.
Thank you, JP. Dr. Makina.
So as Louisa mentioned, the patient had been started on cabergoline 0.25 milligrams twice weekly back in November. She did achieve a mild response and had one menstrual cycle in July with her prolactin around 180. However, she then began not to respond again, and the cabergoline was then increased to 2 milligrams twice weekly. The tumor actually grew in size and her prolactin levels continued to trend up, as you can see here.
Right. And sorry, Amanda,
Yeah.
go on.
Okay. So when she came to Mayo, you can go to the next slide, Louisa.
Okay.
This is what our first prolactin level was here, which was high 346. The point to be made here is that was she actually trending up and was at a level of 346, or had she truly been more in the 300s the whole time? Different lab assays can measure prolactin in different ways, and so it's hard to say. Regardless, the fact that it was this high and she was not responding, she met the criteria for a resistant prolactinoma. Dr. Sampson, anything to add?
No, I completely agree with you. She's already on 2 milligrams twice per week. That is starting to get into the territory where we get concerned about effects on the heart valves over the long term with these medications. So this was why surgery was offered to her.
Thank you, Dr. Sampson, Dr. Makina. So in our differential diagnosis, the most probable diagnosis was hyperlactinoma, with less probable diagnosis in other pathologies in the cellular area. And some important concepts here is the size of the tumor, that we have threshold for microadenoma and macroadenoma that is going to be 10 millimeters in size. That this was a little bit above that. So this is a macroadenoma. After the surgery was suggested and considered, Dr. Donaldson was the one seeing the patient. She performed a nasal endoscopy to check that everything was pneumatized or just per the surgery. And she found there are a few septations and also a left nasal spur, as you're gonna see in the surgical video. So For Dr. Donaldson's perspective, endoscopic endonasal transhphenoidal approach, it was the appropriate choice to go. So the assessment plan, endoscopic endonasal, other options, observation and medical treatment, stereotactic surgery or open transcranial. But for the reasons that we discussed previously, also in Power's presentation, this is going to be the best one. The plan is going to obtain tissue for diagnosis, achieve a maximum safe resection, and illness control management. So this is a photo of the pituitary gland and how vascularized is this gland. Some of the potential risks and complications include CSF leak, endocrine dysfunction, septal perforation, meningitis, stroke, and all the things that we already discussed previously with Paola. And here is the surgical video. We want to start the first part with Dr. Donaldson. I don't know, JP, please, you want to
Sure.
comment?
So here, what you see here, this is the exploration on the left side, and you see basically the first movement is always this one, kind of mobilize and push the left and inferior terminate and middle terminate laterally to amplify the corridor. And you see here Donaldson is injecting the region of where the posterior septal branches will run in the nasoseptal flap, and then injecting the middle terminate right there. And all that helps to control and decrease the bleeding during surgery. Then you see the ostium on the left side. And once the ostium is identified, she can, further open that ostium with a mushroom punch, which I believe that's the next instrument that we're going to see in a moment. Perfect. And after the ostium is enlarged, then you have, the top and the bottom part of the sphenoethmoidal recess, which is the area where through the septal branches will run to supply the septum, and you can just mobilize that and preserve. In this case here, you see Dr. Donaldson is coagulating some of that top part of that area, and it's going to vascularize this posterior part of the septum just to perform posterior septectomy and provide us with access to work in a bimanual fashion. So you see the mucosa is being mobilized. And after she does that, so you mobilize the mucosa, then you mobilize the bone part of the septum. Then here is already working the sphenoidotomy. So you see this is the anterior part of the sphenoid sinus, and she's drilling the face of the sphenoid, and now drilling the intrasphenoidal septations. After that's done, you have got to remember that it's always easy to go down rather than up, but you see, stop right there, stop right there, stop right there.
Sir? Right.
A bit more. Yeah, perfect, perfect, perfect. Okay, thank you. And you see here, this is a view of the posterior wall of the sphenoid sinus, right? Which is already kind of like the skull base. And we always identify the same things, right? And in my opinion, if you can't identify this, probably you're not going to be able to do this as well as you could. So this area here, the center of our approach, and where the gland sits is the sella. Okay, so all of this area here is the sella. When we look on the top of the sella and laterally, you're going to see this first structure and here. And the same thing you would see here and here. So these are the optic canals, okay? From the top of the optic canal to top of optic canal, you got not a bone recess or anything most of the time, but we know, and you use that as a landmark, as the transition between the supracellular space to the actual, what we call like anterior fossa. So, but more importantly than that, the name of this area here, if you open this bone, there is a durafold called the limbus sphenoidale, and it separates the chiasmatic sulcus or prechiasmatic sulcus, which is this area here, with the region of the plano sphenoidale, which is this area here. Why is that important? Because everything below the limbus is infrachiasmatic, and everything above the limbus or anterior to the limbus is suprachiasmatic. So that's like plano and basal frontal lobe, and below the limbus is chiasma. So that's the corridor we use for example, third ventricle and supracellular craniopharyngiomas, which are usually, of course, infrachiasmatic. So here, once you identify those points, you're going to look laterally and you're going to find the red thing, which is the carotid, the paracellular carotid, or I call that the clinoid segment of the carotid, just in reference to the transcranial approach. What you see curving down here then is the paraclival ICA, or the ascending segment of the carotid as it goes into the cavernous sinus. And all this area here would be the anterior wall of the cavernous sinus. This is called the lateral optic carotid recess, and which separates the optic canal with the optic nerve and the superior orbital fissure, which is right here. This big hole is the clival recess, and then everything we described here, of course, is also present here. So we also find clinoid ICA, lateral optic carotid recess. This right here, we can even see the transition on what should be the proximal dural ring, and this therefore should be the distal dural ring. And here we see the cavernous sinus in its extension. Okay, so we look at all of this because in this case we would expect, I'm gonna do one thing here really quick. So we would expect this gland to be around here, and we would expect this tumor to be occupying this region. So this is what we'd expect with this surgery. So let's go ahead, let's continue the video.
Beautiful video, beautiful dissection. And we did this one, JP, with Noma, is that correct?
With Donaldson.
With Dr. Donaldson,
I think
okay.
it was about a month ago or so.
Gotcha.
So you see always the same movements with the drill, a fine diamond drill, and thinning out the bone of the sella. And after doing that, we can use a Kerrison so to mobilize that anterior wall of the sella. And particularly like to drill quite a lot to be able to mobilize that space. And here we're gonna get that piece of bone mobilized to work with that. And then we're gonna expand towards the right side. And you see in this case, I was not, super convinced of cavernous sinus invasion, so I stopped in the carotid here. So I got the carotid, but I didn't unroof the carotid in this case. So same movements, opening, sharp dissection, dissecting with a round knife, preserving the plane with the pituitary gland. And then you see, basically everything looks quite the same. And if you look closely, there would be a small plane here. I decided to go a bit beyond that plane, kind of to try to maximize the resection here and really inspect the gland. But this consistency here is not tumor, that's gland. And then after that's done, start mobilizing the gland and start removing the tumor that was, as we discussed before, on the right side. So tumor is removed, essential pathology, and then you start continue working and mobilizing the tumor to the best of one's ability. Then in this area here, we start going towards the cavernous sinus, and we need to mobilize all that tumor. So you see with an angle curette, you can dissect and use it as a dissector and clean it away from the medial wall of the cavernous sinus. And you can see that wall is clean here. And with that dissection, we can continue working. You gotta inspect, you gotta make sure everything is clean. So we're gonna go and you're gonna mobilize, and I actually spent quite an amount of time working the gland, trying to maximize the resection of this tumor using sharp dissection, as you see there, rather than the curettes, in order to try to not only to remove the tumor completely, but to remove the tumor completely while preserving the anatomy and therefore hopefully the function of the normal pituitary gland. Because remember, she's only 21 years old, so hopefully she can go and get pregnant and everything else. We didn't have any CSF leaks, and you see here the reconstruction was done with biodesign, which is this dural substitute and Surgicel and fibrin glue, and thankfully we didn't have any issues.
Beautiful. Thank you so much, JP. So right now we're gonna go with the pathology, Dr. Gentov.
Yes, here we can see another pituitary adenoma. This time we do not have those somomatous calcifications like we did in the other case. But again, it's a very monotonous tumor. It's falling apart a little bit here, but that's not uncommon with pituitary adenomas. If we go to the next slide. Again, the same staining profile as the last case, positive for PIT1 and positive for prolactin. This supports the diagnosis of a prolactinoma.
Thank you so much, Dr. Gentov. Diagnosis.
Can I ask Dr. Gentov a question about the path report? So the Ki-67 labeling on this tumor is actually quite high at 5 to 7%.
Yeah.
You know, and over 3, we start to talk about, you know, atypical adenomas, although I will say that there's a lot of controversies in what is an aggressive pituitary tumor, but we very, very rarely see these types of percentages for Ki67 as a marker of cell division. And I think that, you know, starts to show you that surgery in this particular resistant adenoma was really the right approach for this young woman.
Under our old WHO classification, this would have been considered an atypical adenoma. There is some controversy behind that. The current WHO doesn't use that as a classification, but they recommend you report out the labeling index if it is elevated. And my understanding is part of it was variation between institution and variation between the percents, and whether it's done digitally or not. We have the ability to do it validated digitally, but right now we have a digital path platform and I can do it on that. It's not validated for me to report it out as being done that way, but I can use that to help me estimate it and get a good idea. But yes, this was elevated.
Do we know anything, Susan, about the chances of recurrence or issues with such a pathological description, as Mark just alluded to?
I would say that because of the historic use of dopamine agonists for prolactinomas, that we don't have a lot of great data on surgical recurrence for this particular type of tumor, but certainly the high Ki67 would make you concerned that you would see recurrence. I will say that I was talking earlier with Dr. Vargas's question about those 60 patients. Over a median follow-up of 6 to 7 years, there were only 3 recurrences in cured patients of those 60. And in those cases, those were already a large macroadenoma at surgery. So I think, well, I won't keep you in suspense. We can look at the results of her prolactin the next morning, but I think this is a really good result in her case. But certainly the prolactin would need to be monitored over time.
And I think, to be honest with you, that Ki67, you know how things in medicine swing back and forth depending on different information. They still recommend it that we report it. I do report it in all the cases, but as I said, I don't make it as part of the classification, but it's really helpful, you know, if this patient recurs, I think, to know that, yes, this had some more aggressive features.
Mm-hmm.
Thank you, Mark. We appreciate those reports. I just wonder whether or not we have any between the 3 sites, whether we would have a good number of patients to review with similar, you know, pathological descriptions or prolactinomas that have been operated on by our group in the recent, you know, 5 years, for instance, because these are modern times.
I think, especially since all the slides are digitized, and once, you know, they're working on different steps within this digital pathology program. Currently for neuroendocrine tumors in the like GI tract, we do have a digital platform that is validated. It's a different system with our Perio. It's much more in labor intense and intensive. And we also do that for some breast tumor cases, but as soon as it's validated for the current platform that we're using to read out the slides digitally, it should be a very simple, quick study. When I do that assessment, it takes a matter of maybe 10 seconds on the screen. But again, we have to clinically validate that still, in which there can be some variations in that. And like I said, I don't know where in that the project overall that is, but I think it's one of the things that they're going to be working on pretty soon, because it'd be very helpful.
Wonderful. We'll put them in the launching pad with Susan. I know that there are some students already here that are asking questions. Susan, this will be a nice potential project to undertake. But I wonder whether it goes even beyond the prolactinoma. So we can look at some of the other tumors that we're looking at, and they have a good gross total resection, at least endoscopically, and then by MRI and so on and so forth. If we can begin to learn to predict what patients may have a recurrence more than others.
Sounds good.
All right, very good. I noticed that for every question that we answer, we have a lot more questions that we don't have the answers to.
Research we start, Dr. Q. That's the thing. Would just keep going and keep answering questions. Well, our patient in her post-op course was based mostly uneventful. She was discharged 24 hours post-op, and she continued follow-up with both endocrinology and neurosurgery. And here, Dr. McKenna.
So as you can see, her prolactin came down very nicely post-op day 1 to 5.6. There was no evidence of adrenal insufficiency with an AM cortisol greater than 15, and no evidence of diabetes insipidus either. So as Luisa mentioned, she was able to be discharged home on fluid restriction.
Thank you very much. Also, we have the post-op images. It's showing nice resection. Okay, I'm gonna go back just to show a bit more this area. Just two. Some hemosiderins residuals and the packing.
Do we have anybody from neuroradiology this morning?
Doctor?
Yeah,
Dr.
good.
Gupta is
Yes,
here.
Dr. Patel. Enlighten us, Dr. Patel. Teach us a couple of pearls, Dr. Patel. The world, 12 countries right here tuning in. Go for it.
Okay, fantastic. It's great to be part of this international effort. So as you mentioned, Dr. Q, very excellent point on the preoperative imaging. There was that hypo-intense band, and one of the things that we make sure to do when we look at these, and I see that we included on this slide, but maybe not on the preoperative slide, is we always include the pre-contrast T1 weighted imaging, because if you look only at the post-contrast imaging, it will not be long before you are confused by something that's intrinsically T1 hyperintense, which subacute blood products often are. So that linear, especially linear division between what was probably enhancing tumor and non-enhancing intrinsically T1 hyperintense blood products was sort of the key to recognizing that there was likely a component of maybe subclinical hemorrhage in that tumor preoperatively. The other reason we always like to look at the pre-contrast T1 is it's rare. You're more likely to find this in a pediatric hospital, but we want to make sure we find the posterior pituitary bright spot and make sure that the gland formed normally and that the posterior pituitary is not ectopic in its location. So it's very important for us to identify that. It also gives us a clue as to where the normal gland is located within the sella, which can be important for guiding the surgical approach to know where the normal gland is relative to the tumor. Because again, when you look at the post-contrast image, it can be difficult to distinguish the enhancing gland from the enhancing tumor sometimes. So those are all important things and important reasons to look at the pre-contrast T1 weighted imaging, which you see here as the sagittal on the left side, and then on the right side you've got a coronal post-contrast image there. So
beautiful, Dr. Patel. And everybody, just so people to know, Dr. Patel has a tremendous experience, in artificial intelligence, machine learning, and he's very, very interesting. We're doing some collaborative efforts now. I know that some of the fellows right here are beginning to work with him. We just recruited him from California, Dr. Patel. Would you mind telling people a little bit about your training so that way people get familiar who you are?
Yeah, sure. Thank you, Dr. Q. Yeah, I'm, as you said, I did my training in California. I did basically all of my training there. I did medical school, residency, at UCLA, and I also did my PhD at UCLA in biomedical engineering, where I worked on computational diffusion MRI and some elements of machine learning there. And so I do have a little bit of experience with that. If you have any projects that might benefit from some sort of that kind of analysis, I'm happy to discuss and help you out. You out there.
Well, we're so blessed to have you.
Thank you. Yeah, I did my fellowship at University of Southern California. So a lot of trauma, a lot of advanced disease. We dealt with a particular kind of patient population, which had a relatively limited access to healthcare. So a lot of advanced disease, a lot of disease you see a little bit more in other countries, a little bit more TB, a little bit more parasitic brain disease. So I had exposure to some of those things as well.
Large population at USC, at the public, the county hospital, a lot of patients with gigantic tumors that come in from Mexico that they just never been treated. The pituitary tumors that you get to see there are the size of an orange, basically. And we're blessed to have you. And so the artificial intelligence, machine learning, I know that already Paola and Diogo are in touch with you because we have a few projects that are feeding back into our grants. So we're blessed to have you, and of course, Vivek and Prasanna and Eric and everybody. So I just wanted to make sure that people know, because it's important that people know what we're doing and that everybody knows what each other are doing, so that we can synergize and add value to each other. So thank you, Vishal. So great to have you. So continue, please, Luisa.
Sir, thank you so much, Dr. Patel. So in the follow-up with neurosurgery, the patient was doing amazing. She was very, very nice, and we recommended to keep the follow-up with endocrinology and just one more post-op control with us, and then define everything is all right. So as a clinical pair, we have Paola had a clinical one, I have a history one. So these are original sketches from Dr. Harvey Cushing when he started describing many techniques, also the transmandibular approach, straight endoscope. So this is a very nice article to see the origin of these techniques that today we just saw. So thank you very much.
Beautiful, beautiful images. Just as a pearl, some of the, I've been blessed to work with many, many of you, over the years. I continue, every weekend I get up in the morning, everybody knows my routine. They send me papers on Friday night. I read them Saturday and Sundays. I start between 5 and 5:30 in the morning. And I've done this my whole life. And I learn from all of you. I love reading because I learn from what you guys are doing. And some of the best, the only papers that I have gotten accepted with absolutely no changes. That means I just flat out, they just get accepted, are the papers that I did with Courtney Pendleton when I was at Johns Hopkins, and they were the papers from Harvey Cushing. I would submit them. I would just put a picture and write something, and boom, and they got accepted into some of the Nature endocrinology, Nature reviews, just big journals, pituitary, you name it. So there's a fascination with the history of our forefathers. We all stand on the shoulders of giants. So Susan, you want to wrap it up and some last pearls for everybody in regards to this fascinating topic of prolactinomas, which was the theme.
Well, could I just share my screen for a sec?
Yes. Can we see how we can make that for Samson? Yes. Who's in charge?
Me.
All right, go for it.
I just want to show you, we have 1 minute. I just want to show you that.
Beautiful. Let's see.
Just in case you think that I'm anti-cabergoline, I am not. But I wanted to just show the trainees this amazing case from last year. This was a 22-year-old male college student. He presented with visual changes, so you can see his loss of peripheral vision. This was his tumor in January 2021. And we started cabergoline. His initial prolactin was almost 3,000. He also had evidence, of course, of hypogonadism. And within 6 weeks on cabergoline, his prolactin was 14. His visual fields, this is from February 1st to March 8th, 1 month. And this was his tumor at 5 months. So when cabergoline has an impact, it's phenomenal. But you also have to be following the patient and understand if you are seeing that kind of response. So in his particular case, this was absolutely the right move to do medical therapy. And in very young men with very large tumors and high prolactins, these tumors do melt away. So just to tell you, I'm not anti-cabergoline, I'm very pro-cabergoline, but surgery is the right move in some of our patients.
I love it, Susan. You just remind me of a patient that I had with Dr. Roberto Salvatori.
Uh-huh.
All right, my Italian compadre, he and Alessandro Levi and I, we did a lot of pituitary tumors at Johns Hopkins, and Roberto and I had a patient that it was a nurse at Johns Hopkins, same young, he was 26, huge tumor, bitemporal hemianopsia, and the prolactin at that time, this was 2007, the prolactin came back, you know, around 100. So they thought at another institution, he was getting care at one of the local hospitals and came to us, and Roberto realized that it was not diluted. And it turned out that it was a prolactinoma. We put him on medication, same deal within a month. He had bitemporal hemianopsia, you know, within a month, you know, the whole tumor. So I do believe that it is a blessing to have those kind of medications, to have people like you and Roberto, you know, taking care of these amazing patients that are very complex. So beautiful results.
Excellent.
Excellent. Great, Pearl. Andrea, do we have an announcer for Monday? Speakers, what do we have on Monday?
Yes, we have Dr. Leonardo from Allegheny in Pittsburgh. She will be presenting the PARS paper, Perceptions versus Misconceptions, Training the Modern Neurosurgeon.
Amazing. Jody is an amazing colleague, friend. She trained with Dr. Talk. You know, they're very, very good friends, and she's wonderful. So please join us from around the world. I know we have people from over 12 different countries. So we're delighted. Susan, thank you for your extraordinary leadership. I don't know if people realize how much we have grown in the Pituitary Center. In 2006, when I came in, we were doing single-digit cases in pituitaries. And this last year, we ended with over 100. So there's been a tremendous growth, and that continues to grow. We see it every week. We see the type of cases that you are managing, and our patients are blessed. Not only are we increasing number, but the length of a stay is almost less than 24 hours, if I remember correctly now. So it's just been a tremendous blessing. And what people don't realize is that when I operate on Thursday, you are on the whole weekend, because your fellows in this case, you know, they're on taking care of the patients on the weekend. That's the only way they go home. So there's a lot of work that goes behind the scenes, the unsung heroes, and I thank you. It's a great blessing. And I thank JP, and I thank Gabriel and Kai and neuroradiology and neuropathology and everybody. So a great blessing to learn from all. Have a great weekend. We're going to go to the operating room now. Adios.
Adios, adios.
Bye. Thanks, everyone.